Good morning, everyone. My name is Agnieszka Sznyga. I'm representing Innovo Institute for Innovation and Responsible Development, and I would like to welcome you all warmly from the beautiful Prague. And we are very happy to be here with such distinguished experts, which are great experts in oncology. And today we are meeting because of the Oncoroundtable, a special webinar, special expert roundtable, when we can exchange knowledge, experience, best practice, and discuss how to optimize the patient care in oncology. Today is actually the fourth meeting which we already discuss the topic. With some of the experts we already met in few other occasions. And today we are focused on two therapy areas, lung cancer and prostate cancer. This event is organized with cooperation of Polish Personalized Coalition and also Polish Oncology Association with support of Philips. So now, let me introduce our great experts which are here with us, and also some of them will join online. So first of all, Professor Martina Koziar-Wasakowa. Good morning. Professor is the head of Department of Respiratory Medicine of the First Faculty of Medicine, Charles University and Thomayer Hospital. Good morning.
Good morning.
Online with us is Professor Hendrik van Poppel from Catholic University of Leuven, and also he's a head of European Urology Association, and we're really happy that he was managed to squeeze us in his tight agenda because he has like plenty of meetings today. We have also online Professor Hans-Ulrich Kauczol. He's Director of Translational Lung Research Center, Heidelberg. Next to me sitting Ante Marusic, TMC Clinical Lead for Lung Cancer Screening, yes, in Horvatia and UK. Good morning. On the other side, from Polish, our Polish expert, Professor Joanna Chorostowska, Head of Department of Genetics and Clinical Immunology, and the consultant in respiratory medicine in National Institute for Lung Diseases from Poland. Hello. We have also from Czech, Professor Lukas Lambert, Head of City Department, Radiologist, General University Hospital and First Faculty of Medicine, Charles University from Prague. Good morning. And online, Professor Gabriel Casco, Medical Director of the Amethyst Radiotherapy Center Cluj from Romania. And Ilya Glib, Medical Officer from Philips. Also with us, we have some systemic experts, so I would like to warmly welcome Adela Magehar. She's Senior EU Affairs Manager in European Patient Coalition. Good morning. And we have also Diana Loreta Paun, Presidential Advisor and Department of Public Health from Romania. So today's session will be actually, this Oncoroundtable will be divided in two sessions. First session will be more targeted to clinical topics, when we can exchange knowledge about, early diagnosis, screening, therapies of the lung and prostate cancers. And the second session will be more targeted to the systemic policy issues, how we really can build the whole kind of system to really improve and optimize the patient care. So now, I give the voice to our great experts. So please, first, Professor Martina Koziar-Wasakowa, the floor is yours.
Yeah, thank you for your introduction and for your kind invitation. I'm pulmonologist and immunologist, and I'm like a mother of lung cancer screening in the Czech Republic, which was initiated in January this year. May I have my presentation? Yeah. In general, I will talk, because I'm pulmonologist, about chronic lung diseases burden, because the lung diseases cause a very high proportion of all deaths worldwide, more than 4 million it was in 2017. There is increasing incidence of the lung diseases, and they remain the main reason for ineptability and invalidity. Within these diseases, one of the most severe is lung cancer, which is first in the causes of death in malignant tumor, then COPD, which causes a very high proportion of deaths, and also progressive pulmonary fibrosis and tuberculosis, which may pose a threat in Europe after the migrant crisis as well. And also COVID-19, which was cause of the death in 6 million people worldwide, but has caused the 15 million more deaths in the last 3 years than in previous times. The main trigger of the chronic lung diseases is tobacco smoking. It's definite, and it cannot be said that the smoker is an innocent victim and there is only dirty environment. That's not true. But the dust and inflammatory pollutants also contribute to the initiation of the events in the chronic lung diseases, and maybe also stress, obesity, and lack of physical activity, which is quite frequent in our developed world, and low quality nutrition. What about tobacco? Tobacco kills each 4th one inhabitant of planet Earth. I think this is very important message, and we must be aware that fight against smoking, not smokers. Smokers are people. Against smoking is one of our biggest goals, especially us of pulmonologists. And 8 million people annually die of use of tobacco. Tobacco increases risk of many diseases, but lung mainly, because it's directly inhaled to the lungs, the tobacco smoke. And there is 22 times increased risk of lung cancer compared to non-smokers. 2 times increased risk of latent tuberculosis infection activation. That means that smokers have also more frequently active tuberculosis. And 1 of 5 tobacco smokers develop COPD, which is a very high number. Also, children of smokers are at risk of development of asthma, and smokers are at risk of development of pulmonary fibrosis and all infections. That means also COVID-19. Only in short, COPD, according to frequency, with increasing age, that means in the population 70 years and more, there are 20% of individuals suffering from COPD. And acute exacerbations, which are very severe episodes in the course of the disease, COPD, cause more deaths and increase the probability of death in the consequent years. You see the 4 years after the first exacerbation, nearly half of these individuals die of COPD. Progressive pulmonary fibrosis, this is like group of diseases. This is not one disease like idiopathic pulmonary fibrosis. Now we know there is a much wider group of the diseases, very severe, with some of them with mortality like in lung cancer. And their incidence is also increasing in developed world. And if you have acute exacerbation with lung fibrosis, you have a chance 90% to die of this event. And now to lung cancer, because we are to talk mainly about oncology today. This is malignancy with the highest mortality. Not in the Czech Republic only, but in all the developed countries of European Union and America. And unfortunately, the incidence is still increasing, mainly in women. And tobacco smoking is the reason for lung cancer in 90%. In 2018, there were more than 2 million of new cases of lung cancer, and more than 1.5 million died of lung cancer. That says that if you have diagnosis of lung cancer, you have the high probability to die of lung cancer. Yeah. And what is sad, truth, that only 10 to 15% of lung cancer patients can be cured, because we have many patients which are diagnosed, the majority of patients diagnosed in advanced phases of the disease, where the lung cancer cannot be cured. This is a table of the mortality of all cancers in the Czech Republic, and you see that the lung cancer is on the first place in women in the Czech Republic. And now you see the stages at the time of diagnosis in the Czech Republic. I have told you a majority of the patients are unfortunately diagnosed very late in the course of the disease. And you see that the stages from 3 to 4, that means those stages which cannot be definitely cured in a majority of the patients, is more than 70% of newly diagnosed cancers. So how to prevent chronic lung diseases? Better is, or the best is the prevention. That means to educate people not to smoke, to make intervention in every new patient, not only at pulmonologist's office, but also in every specialty and GPs, at internal departments. Every physician has responsibility to ask patient about smoking and to make short intervention to support the patient to get rid of this behavior. We should propagate healthy lifestyle, and what can we do, and this is very potential tool, screening programs. The early diagnosis of lung cancer may save the lives. In the Czech Republic we have lung cancer screening like a pilot, but all over the Czech Republic from January this year, and this is in Czech, but there is the pathway of the patient. Patient is approached by general practitioner, then if the patient agrees to step into the program and agrees with the intervention against smoking, proceeds to the pulmonologist. There is checked if the patient, not patient, but client, if he is feasible or eligible for lung cancer screening, and if yes, then it is sent to radiologic center and for the first investigation, and then there are scenarios according the findings that mean either negative, that means that the next investigation is in 1 year and then 2 times in 2 years, and if positive, then it is sent to the pneumo-oncosurgical center, and if intermediate, then the check, the radiologic check is planned earlier. What are the inclusion criteria? This is the age, this is 55 to 74 years in the Czech Republic. There are minor exceptions, that mean patients, for instance, with lung fibrosis or asbestos exposure, there can be less smoke exposure, but we must be aware that the health insurance funds do not pay for any individuals who are not within this range, which is in the methodology of the screening. The patient can be also ex-smoker or the client, and there should be at least 20 pack years. Very important is willingness to take part in smoking cessation program. Yeah, it doesn't mean that the individual must quit just now smoking and promise that he will never smoke again, but that he will undertake intervention to stop smoking, and no severe comorbidity which can influence the survival in next 5 years. What are the early experiences? There were more than 4,000 patients approached by general practitioners, but unfortunately only half of them agreed to take part in the screening program. They attended the pulmonologist and then underwent the radiologic investigation. It was the half of October. At radiology were investigated at that time 900 patients, and we have valid reports for 891 patients, and you see the results in this cohort. That means the green one is negative. This is more than 68%, and then we have the blue one, which is like indeterminate, and nearly 5% of positive findings. So that means these are the people who were already referred to the pneumo-oncosurgical centers. And here are the number of nodules which were revealed at the radiologic investigation. The majority of individuals no nodule, then 22% of patients one nodule, and you see there were patients with more nodules, 1/4 of them 3 and more nodules. Now we are trying to create again a campaign in the media to support the lung cancer screening program, because to prove that it is effective, we must attract really not majority, but at least a substantial part of the smoking population of the Czech Republic. We estimate that there is 500,000 individuals potentially available for the screening programs. So if we have 100,000, we may be lucky for the pilot phase of the project. So we propagate it at the conferences, at TV, and this was one of the spots at breakfast with Television Nova, which is quite great impact. And we also share our experience with Europe. We got a nice seminar. Joanna Chorostovská was one of the initiators of this event, which took place in Brussels in a permanent representation of the Czech Republic. And we also are partners in the SOLACE project, which aims to implement lung cancer screening in Europe. Now ERIS is trying, European Respiratory Society is trying our best with advocacy group to promote the idea of implementation of lung cancer screening with European Commission to influence positively the member states of European Union to support these programs, which from the expert point of view are really good to implement to save the people's life and increase lung health. Thank you for your kind attention.
Thank you very much, Professor Vasakova, for this overview of situation in Czech Republic. So now let's go to Brussels and let's connect with Professor Hendrik Van Poppel, and let's find out a little bit about the prostate cancer and the situation all over Europe with this disease. Good morning, Mr. Poppel. Can you hear me?
Thank you. Good morning. I hope you can hear me. You hear me well?
Yes, now we can hear you. Yeah.
Okay. So I first want to thank Agnieszka Snick for allowing us to also bring prostate here in the in this auditorium, which is mainly focused today on lung. You know that together with gastric, prostate and lung are on the hopefully new recommendations in screening. I'm a urologist based in Leuven, in Belgium. I'm now in Brussels, close to the European Parliament. I'm the chair of the policy office of the EAU. This is the European Association of Urology, with around 20,000 members worldwide. And since my last 5 years, I have been fighting hard to get prostate cancer screening on the agenda and hopefully in the BEAT cancer plan. Now, if you maybe can give my slides.
It's always moment of truth, so yes, it's okay. Well, it's, they already there.
Okay.
So it is?
I don't see them.
Yeah, oh yeah, now it is. So we are on the safe side.
All right. So I would like to give you the approach of the EAU that we have been proposing to the SAPIA and to the Commission. Now, the first question, obviously, I try to advance the slide, but my clicker is muted. Okay. So why did the EAU have to undertake something? The first thing is that prostate cancer is an important health problem. And we just heard about lung, but I can show you the figures of prostate cancer mortality in the European Union. And you see where Belgium is, you see Poland and the Czech Republic in the middle, and then you see the Baltic states, Scandinavia at the top, while Spain and Italy are really at the bottom. For the Czech Republic, with 10.5 million people, we in Belgium have 11 million, and there is 4 men die from prostate cancer every day. Now, the second point is it kills more than some time ago. And this is strange because we have better diagnostics, better therapeutics, still more people die. And you see that initially diagnosed in stage 3 in Germany, there was 29% in 2008, and it's 50% in 2017. Still, we can cure some of these, but many of them will become progressive and will die. So in Germany, prostate cancer has become the number 2, as it is in Belgium, as it is in the Netherlands. And in Sweden, the Baltic states, it is the male killing cancer number 1. This is, for instance, in the UK, where you see the green graph is prostate, the red one is breast. Well, in 10 years, there's been an increase in prostate cancer death by 17%. And today, more men die from prostate than women from breast cancer. And this is even more important. This is the metastatic state at diagnosis. And you might have seen a very recent publication in JAMA Oncology in the United States. Between 2005 and 2019, the number of metastatic patients has increased from 4.6 to 5.3 million. So there is an increase after the recommendations by the United States Preventive Services Task Force against screening of men with prostate cancer diagnosed at the metastatic stage.
Nu am trimis chestia la frecventă să fie.
Okay, just to come to Belgium, a country somewhat comparable to the Czech Republic, you see there has been an increase in PSA testing, but then after the American recommendation against, there has been a drop, and even recently a further drop in PSA testing. And this is the consequence. This is very clear figures on the mortality of prostate cancer in Belgium. And you see this increase as from 2005 up to where we are today. The third point is that prostate cancer is terrible to die from. The doctors, the nurses, those who have taken care of patients dying from prostate cancer realize how painful this disease is. All these men have been castrated 2-3 years before, have a bad quality of life, and then finally they die suffering enormous pain because of the osteoblastic nature of the bone metastasis. This is really bone growing in the bone that makes it so painful. And moreover, the cost of this is very expensive. Because if you look on the left, what is the cost of surgery and radiotherapy? In this man that was detected too late and became castrated because of metastasis, you see that in the end of his last 2 years, to prolong a poor quality of life, the life expectancy with 2 years, you got all these expensive drugs that amount for 240,000 euros as compared to the 10,000 euros of treatment of curable disease. The fourth reason is that screening has been shown to decrease mortality, but at the cost of overdiagnosis and overtreatment. And I think that you know all these graphs. This is, on the left side is the European randomized, on the right side is the Göteborg trial, and you see with long follow-up, the reduction in death due to prostate cancer increases up to 44% after 14 years. We have now figures after 20 years, where the metastatic rate and the death from prostate cancer decrease for more than 50%. So nobody today can say that there is only a modest influence on prostate cancer mortality. There is a huge influence on prostate cancer mortality, but at the cost of overdiagnosis. And this is what you clearly see with the blue arrow showing where we started to do PSA screening and the subsequent overdiagnosis that after a couple of years became to the just increasing incidence over the years. But what you see at the same time at the bottom is that a couple of years after starting PSA testing, there is a clear decrease in mortality. Don't hear me say that it's due to screening only, but it certainly plays a factor. And look what we did between 2005 and 2009 when it comes to reducing prostate cancer mortality and all the other cancers. How poorly did we do for bladder? How excellent did we do for prostate? But indeed, with overdiagnosis and overtreatment, which has resulted in this United States Task Force recommendation against prostate cancer. But screening decreases prostate cancer mortality. The fifth point is what we do today, and I was in Prague last week discussing with the Minister of Health, Mr. Valek, and with my colleagues. Opportunistic screening is costly and it does not influence population prostate cancer mortality. And this has clearly been shown. On the left you see what organized screening does. On the right you see that wild opportunistic screening has no effect on prostate cancer mortality and it does not avoid overdiagnosis and overtreatment. So this is not the way to go. It is costly and we need to stop this happening. So what did we do? We talked to the policymakers to make them aware of these 5 points. We had an excellent opportunity with the Beating Cancer Plan from Ursula von der Leyen, and we prepared a novel way of early detection, where we avoid overdiagnosis and overtreatment. And we started by giving some patient information, as you can see on the right. We gave guidelines to our healthcare professionals, but most importantly, we went to the policymakers with white papers, as you can see, successively in a couple of years, the last time in 2020. And we went to the European Parliament. And you see on the left is Monique Robel, who is the mother of prostate cancer screening in Europe, and who is the first to recognize that within ERSPC, where we showed mortality decline, there was this harm done by overdiagnosis and overtreatment. And so she knew very well that we need to change this. And this is what we have put together in a paper in European Urology for the European Union and the European Commission, just to tell them how we want to do it. We want to better use the PSA, age-related, related to the volume, what we call PSA density, and then use risk calculators. So not everybody who has a PSA above 3 will have a biopsy. Second, when with the risk calculator, it seems that he is at high risk of having significant cancer, he then first has a multiparametric MRI before he has the biopsy. And we can discuss this further. Maybe a biparametric MRI in this setting would be as good, but this still needs to be shown. But it would cut down the price and the time spent. Second, we are able to reduce overtreatment by application of active surveillance in 65% of diagnosed low and intermediate risk prostate cancers. And we have today nomograms that can reassure us and reassure the patient that you, good man, you can continue on active surveillance safely and you will not need active treatment yet. Or you are now at risk and active treatment should now better be procured. And this is the algorithm that we have designed. And without going in too much detail, you see that a man with a PSA below 3, does not need any further investigations. He needs to come back for another PSA check. Or when he's older than 70, he does not come back anymore because there's no use of continuing doing PSA testing. But if the PSA is above 3, he will be risk stratified. And this risk stratification can be done with the ERSPC risk calculators, but there is many others where you can then calculate with the age, the volume of the prostate, the age of the patient, the family history, whether he has a risk of a positive biopsy. And when that is higher than 12.5%, he does not now undergo a biopsy yet. He will then first have a multiparametric MRI with, again, a new stratification of risk. And finally, a percentage around 35% of all those who had an MRI will in the end undergo biopsies. A quarter of them will have cancer that is amenable for active surveillance, and 3/4 should go to active treatment. So we really have made progress just with the reflex testing on the one hand and with the MRI. And you see in the green ball, the blue ball shows all the patients that do not undergo more than a PSA test. They do not become patients. This is just healthy males that stay out of the medical world. And you see that in the end, there is a number of prostate cancers, significant prostate cancers detected that can be actively treated and prevented to die from prostate cancer. So PSA is not very expensive. A multiparametric MRI, I think we need to keep the cost down, and maybe biparametric will be a solution there. And early detected significant cancer treatment is not too expensive. But by doing what I proposed, we will have less biopsies, less complications of the biopsies, less treatments, less overdiagnosis, less overtreatment, no costly treatment of this very expensive castrate refractory disease. Less men will die with an increased professional lifespan. And finally, those men that get prostate cancer will have a much better quality of life when they have curative treatment and do not progress to the metastatic stage. So how have we proposed to the Beat Cancer Plan to eliminate the second most killing cancer? Is just by doing this population-based organized screening, the way I explained you, biopsy only those at risk for significant cancer, treat actively only those at risk to die from it, so that we decrease the mortality, improve the quality of life, and decrease the cost. So there is now, today, 4 reasons to change. Today, we need to decrease prostate cancer rates, like breast, cervix, and colorectal. Stop the increasing rate of late diagnosis. Stop the costly and inappropriate, inefficient, opportunistic screening, and improve the quality of life of patients. And here the solution is organized population-based screening. The solution is not to ask us to do new randomized clinical trials to show that with MRI we do better, with Stockholm 3 we do better, with 5 we do better. This will all improve and further reduce overdiagnosis. But we do not need randomized trials that take 25 years before getting the results. We need to do this now. So 25 years after ERSPC, after all the work that we have been doing in the last years with the Commission, with the SAPIA, what have we achieved? Well, the SAPIA, the experts, find, after hearing all the experts, opponents, people in favor, epidemiologists, urologists, oncologists, they have found the scientific basis for organized screening for prostate cancer strong, and it is likely that MRI will become a very important part of this when age criteria are respected. And we have in the meantime, exactly like the pneumologists and exactly like the gastric have applied for a grant, a call from the European Union for Health, 10 million euros for the 3 diseases for a program of 3 years, where we need to show the state of play that you see on the left side, where we need to tell what the countries do today, what they have available, if they could afford it. And then we have a number of pilot studies. One of them will be done in Poland, another will be done in Spain, in Ireland. We work together with the Czech Republic, we work together with Estonia, we work together with Sweden, and we hope that we will finally, in this 3-year program, show that it is feasible, that it is cost-effective, that it improves the quality of life, and that it's psychosocially acceptable. And we will continue to work with a very strong consortium. The grant has now been given to the 3 programs, and I hope that also for gastric and lung they will be successful. I can tell you that it is unbelievable how many countries that are not involved in this project are now showing interest. Just to say Norway, Finland, Latvia, Georgia, Moldova, Slovenia, Ukraine, Bulgaria. So it's going to become a European, not only a European Union endeavor.
Professor Popel, I think we have to a little bit run out of time, so if we can...
Yeah, but I am finished, and I apologize when I spoke too long, but with the echo, it was a little bit, I was forced to speak a little slow. But thank you for your attention.
Thank you very much, Professor Popper. And now we're going to Germany, and I give the floor to Professor Hans-Ulrich Kautscher. The floor is yours.
Thank you very much. So my name is Hans-Ulrich Kautscher. I'm chair of radiology at the Heidelberg University Hospital. And I'm very happy that just very briefly will update you on the best practice solutions and barriers for lung cancer screening. These are my conflict of interests. So one is lung cancer screening has a very high evidence. It has been shown by multiple randomized and non-randomized trials with long-term follow-up that there is a significant reduction in mortality from lung cancer. And you can see on the upper right-hand side all the odd ratios of the different trials from the US and from Europe, and all of them are in favor of lung cancer screening. And so far, lung cancer screening is the only risk-based screening population that is addressed, as it is different from other screening programs which are out there right now, which focus on a gender component and or an age component, whereas smoking is the risk for developing lung cancer, so this is added to the age component. This is very important because we have to work on promoting also our other screening activities towards a more risk-based selection of people who will be recruited for these programs. And it has been shown that it is even more effective in high-risk individuals. So just a little smoking is not just enough or will not provide very convincing results, whereas heavy smokers who have smoked a pack a day for 20 years, 30 years, will have a very high risk of developing lung cancer, and also lung cancer screening will be more effective in this group. And from multiple healthcare systems has been shown that lung cancer screening is cost effective. So what is important right now, you can see in the right lower corner, November is the Lung Cancer Awareness Month, so this is now, and the revised EU Council cancer screening recommendations now offer a unique opportunity to curb mortality from the leading cause of cancer deaths, as has nicely been shown in the first two presentations. So we are looking at a very, very frequent cancer, which is the #1 killer in men and women alike nowadays. These are all the randomized trials from Europe and the US. They had slightly different eligibility criteria with regard to age and with regard to their smoking history, but in general, it is between 55 and 75, and it is about at least 20 pack years, and then quitters of less than 10 years should be recruited as well. And what we've seen a development towards volumetric assessment of pulmonary nodules, which are the ones that these algorithms are going to tackle. And based on volume, the calculation of volume doubling time is our major key to assess nodules, which will then go for further diagnostic workup. Where we are now, this is a very nice interactive map, actually, that has been put together by the Lung Cancer Policy Network, and I'll refer you to their homepage. And it nicely shows all the European countries with having clinical trials, implementation studies, regional programs or national programs out there. And I'm very happy to see that there are so many dots. And there are national programs out there already, and there are multiple implementation studies in multiple countries. And I think we will have to promote this to more and more national programs in the next 5 years. So within the European Beating Cancer Plan, I think it's important implementing lung cancer screening and then add innovations to it to really make the results of randomized trial work in a real world scenario. We will have to increase the impact of the algorithms. We have to overcome the bottlenecks for recruiting the high-risk individuals, and we definitely have to tackle inequalities throughout Europe, but also within individual healthcare systems. So what are the solutions? Very busy slide here. Number one is it is done by CT. It is done by low-dose CT. And there are new measures out there which will reduce the radiation exposure by an order of magnitude, so by a factor of 10. So moving it to really ultra low dose so that radiation dose is not going to be anything that will be affecting the participants of lung cancer screening. We have to work on bringing the false positive result ratios down, for example, by the use of special algorithms like lung rats. We were working on reducing overdiagnosis by the introduction of risk models into selection of people participating in these studies, as well as their intervals. Artificial intelligence and seamless IT throughout a regional or national program is very important. As you can see in the middle graph, 1% probability, 11% probability of a nodule being malignant will be incredibly helpful. We will go for assessment of comorbidities, so other tobacco diseases, tobacco-associated diseases, as well as incidental findings, probably trying to move this lung health check to the big three, which is what Martina already showed us: lung cancer, COPD, and cardiovascular disease. It is important that we move these implementation trials to make sure that we reach out to the people who will definitely benefit, that it's affordable for the healthcare system, and it's accessible for everybody who fits the eligibility criteria. And it has to be joined with tobacco cessation interventions in order to have a very comprehensive program. Thank you very much.
So, what is the situation in Croatia, Dr. Ante Marusac?
Hi, hello to everyone here and online. May I get the... Yes, this thing. Okay. Thank you for the invitation. It's so nice to have a multidisciplinary team here. So there are a few radiologists, which is a nice thing to have, not so often, and it's nice that radiologists are also involved in oncology. It's extremely important. So I am a radiologist in lung cancer screening in Croatia. I used to be a radiology lead. I'm still something like that, more than a consultant at the moment. And in telemedicine clinic, I do a clinical lead. I am a clinical lead for lung health check program for our UK clients, and we do a substantial proportion of those screening cases in the UK as a company. So let's say something about Croatian screening program. It's nationwide program. Why did we go for it? Because Croatia has the second highest incidence in the EU after Hungary. And as Professor Van Poppel said, it's time to act, not to do any more trials or discuss further. So we decided, okay, let's go, and we started 2 years ago, as you probably all know. I'll try to say what did we do, how did we try to organize that. You know, it was quite a bumpy road to start from nowhere and get to where we are at nationwide screening, and everything is much slower than in projects. In projects, many things are different. So let's start with high-risk population detection. So we could use, as we said, age, smoking history, and quitting smoking in last 15 years. We said 15 years, and we took 30 pack years of smoking history. Now we know that 20 pack years is recommended, but now we can't change it, you know, until this round is ending, meaning, you know, in the legal point of view, then we can introduce something new. For now, it's just not possible. So in the next round, we will reduce to 20, probably, and even more, we would like to introduce risk models. So, why did we go with those simple criteria? Because they do detect high risk population. We are aware that risk models are much better. But you know, in projects, you employ people to do it, those who really are willing to do it. And when you do a nationwide screening, you just need to involve all GPs, for example, as in Czech Republic is the same thing with GPs. And they are not all of them are interested. So you have to make it really simple as possible. And that's what we did. So we produced a kind of software which had to be developed from the beginning. And one part of it is on GP's side, so that they can have inclusion and exclusion criteria, and it's just easy. And then another thing, they have been they have informatics for a long time now, and they have certain panels for cardiovascular diseases, for example, or COPD, where they were already taking record on smoking. And then we tried to make those existing software solutions to produce alerts to them which of their patients are eligible for screening. So those who are really interested could do even active search through their panels and their lists of patients, and those who aren't are doing just, from time to time as a patient shows up, they can do a motivational interview with their patients and then try to enroll them into the program. Are we happy? As I said, we are not, and probably we should go for risk models. Reaching target population is something that was quite a problem, especially for those people who belong to lower socioeconomic status. And thinking about it, how did we try to solve this problem? GPs maybe are the key, and I think that that key really opens the door. The GPs do have a communication with most of their patients. At least in Croatia, the whole population is covered with GPs. Everyone has to have a dedicated or elected GP, and there are 2,100 GPs in the country. The whole population, basically 90% of patients visit their GP during the year, which means vice versa, the GP can see the whole target population within 1 year. That was interesting. The GP has a special relationship with their patients, and patients trust them, which means that on the response rates are higher. So now there is a bit of problem with this primary response rate, let's say, from the population to referring to CT, because we miss one small button which should be added later. So it's difficult to know how many patients were contacted and how many really wanted to participate in the program. That should be settled in near future, hopefully. But as I told you, bureaucracy is a bit slow, and then it takes time to sort all those problems out. But the secondary, let's say, response rate, if we call it that way, those are how many patients do show up on scanning on CT after being referred by GP. It's over 95%. So almost everyone comes there, and those who do not attend are keen to call and ask if it's possible to get another time, another slot to do the scan. And that is really, really good thing, because there was also problems with that in some trials, and there is no problem with it in Croatia, and that's because of this relationship and this trust in between patient and their GP. Nodule protocol, difficult diameters, volumes, of course. Europe is on volume, and we decided to go for volume. Professor Kaučer said nice things about it, showed all the trials and the sizes, different sizes and different measurements. From his previous lectures, we learned that basically with increasing size of significant nodule, we reduced false positive findings. And that's simple as that. Every year, 2, 3, difficult. It's been now okay to go every 2 years. It's been safe, but we left that one security key on the beginning. So the first follow-up is at 12 months, and then every 24 months for those who are negative, let's say, or have nodules smaller than threshold. So what have we done? We compared three. There was a nice publication from Claudia Henschke and colleagues showing basically how many biopsies, for example, are needed to prove one cancer, or how many participants were considered for biopsy at all. And then it seems that ILCAP picked up the least number of those who should be biopsies, and then you need only 2.2 biopsies to prove a cancer. For example, Langrad's, let's say, this version second with volumes also introduced are 3.2, or EUPS is 4.4. And this is really, this reduces anxiety and reduces costs and unnecessary work, of course. And this is our protocol. We used ILCAP. With this ILCAP, we introduced into it the volumes. As you can see, it's 150 to 2000 millimeter cube, which is equivalent of 6.5 to 15.5 millimeter in average diameter of the nodule, which has been followed up. Below 150 millimeters, we do not do anything about it. We treat it as negative, basically. It wasn't all. We had to introduce the categories into it. Why? Because we thought that it would be good to have things categorized to make a recommendation which is standard, which is always the same and independent of the radiologist who is really doing it. You know, if you have a nodule which is 300 millimeter cube, and you, as a radiologist, decide that it is a nodule, which was picked up by CAD and measured by software, then you can include it into the report, and then the recommendation will be automated and the same for everyone. And that's why I think that these categories are good. Why? We will say something later about it. Pulmonary nodule management, that's again an interesting issue to talk about. Multidisciplinary team, when to do it, how to do it. Is it the same in some projects or in real world approach? So what have we done? We decided that multidisciplinary teams are not that established in Croatian healthcare system. And for example, in the UK is different. In the UK healthcare system is really based on multidisciplinary teams all the time. So instead of sending patient with a positive nodule, let's say a positive finding, we could say finding because consolidations are also positive finding. We send the patient to pulmonologist first, and that pulmonology is that pulmonologist, or nodule clinic as we call it, is included into the screening program. So it's still generated, the referral is generated through this part of the software. Multidisciplinary team, we left it for the end of the workup, the workup is needed, because we think that pulmonologists can really decide if the workup is needed or it isn't needed, or maybe we could do some follow-up differently if they think it's inflammation in there. So we saved some time for everyone for this multidisciplinary team like we have today here. Communication, that's what I said, bumpy road. We had to build up the whole system. There are many things, again, that we are not happy with, but we couldn't copy it. We just had to build it from the beginning with IT people who are not really close to medicine, and it was really difficult sometimes to explain what we need, how it should look like, how it should work. That's what we did. Are we happy? No, it has to be improved further. It has to be better. We do have, for example, also regular reports, statistical reports, which are important. But again, there are some things missing there. And then if we want to go manually through, to search through the program, it's a bit of complicated procedure because we have to get permission from national insurer and the company which owns the program, and after all, Ministry of Health, who is the owner of the whole program. Smoking cessation, yeah, it's a good thing, it should be there. We had 22 centers, 23 centers before pandemics, which were functional, and at least 100 GPs educated to do smoking cessation programs. But after pandemics, unfortunately, we have only 3 centers now working on it. But as you said, every GP should basically teach and learn their patients. It's not good. So are we happy? No, we should improve that further and think about it. Big problem, incidental findings. How to control them in real world? It's not the same thing as projects. So we rely on our, and what are, after all, incidental findings? Is emphysema incidental finding, which is mandatory to record. I don't know, it's just a part of the program, it's not incidental finding, we expect it, but again, we are not quite sure what to do with it. When does it go to pulmonologists further? That's a pathway that we have to establish better, more clear to GPs, and now we are trying, we are writing a publication for GPs to have like navigation, what to do with incidental findings. Maybe even that navigation, those guidelines should be a part of the report from the radiology. At the moment, radiologist has a box to write down recommendation what to do with the incidental findings. So again, we have to improve. Education, professional requirements, what to do with it. It's nice. At the moment in the UK, it's more than 500 CTs. Thoracic CTs is a requirement, most of which should be related to lung cancer. How many radiologists would be eligible in Croatia for that requirement? 10? 15? Impossible. We took 300 CTs, CT thorax, not related exactly to lung cancer. And then we did education once, twice, and so on, how many needed. At the moment we have 70 people who are involved. We have regular reports, so with through those reports we can try to improve. Our radiologists, we still did nothing really straight on them, but we should control that better. So not happy. Cost effectiveness, this is one of the works that you can find on internet. It's extremely complex. We do not have capacity to do that, but it has been shown through so many studies that it's cost effective, and I don't think that it's needed to be calculated. And we even know that for countries which have cheaper exams, that cost effectiveness is even better. So if Nelson showed that cost effectiveness is okay, is good, even better than Nelson, and better than NLST, and because again of the price of the exam, and it's cheaper in Croatia than in Netherlands, for example. So these are our results. At the moment we have these numbers on everything about only the number of cancers is old data, a month old, let's say, but these are from yesterday, others. So, you know, giving data is always a problem. We waited for Nelson really long, and this is a live thing. So we did 11,590 scans. During these 2 years, baseline is about 10,000, which makes some 20% of our population, targeted population. We should increase that, but campaign is really important, public campaign to get more people and to raise awareness again. Negative findings are altogether 82%. Why? Because the size of the nodule is really large. And then semi-positive findings are 12%. Those are those of in between 150 and 2,000. And we have 292 positive exams on the baseline, and another 180 which grow in less than 400 days volume doubling time on follow-ups. And from all of that, we have 108 malignancies. We had, but now there are more, because some of those are not included, some are still in workup, and some are in these numbers. You know, a month or even longer is a long time, so this number is larger. So the bottom line is 1%, but there is probably more. Some people are lost because they just go other ways to surgeons, and they are really anxious, and then take it out, the nodule, and we have no idea what happened, unfortunately. So you have to track everything manually. The important thing is that effective radiation dose is 0.9 millisievert to all screening, and on newer machines like we have in our clinic on Jordanovac is up to 0.5, but up to 0.5. Mean is probably 0.34. We didn't calculate that. So what are the ingredients to start nationwide low-dose CT screening, lung cancer screening? Political will on the beginning. It's, of course, money issue. Without it, there is no way to do anything. Leading people, team, has to have dedicated time for that. So Ministry of Health has to employ people to do that. The team has to be employed. From administrative people to radiographers who are close to IT, or even some IT person, and of course radiologists, pulmonologists, thoracic surgeons. Everyone has to have some dedicated time. For example, leading radiologists should be employed on that project at least 1 day a week. Otherwise, it's just too much to set it up and to follow it up. It's difficult. It takes time. And you need analysts, after all, at the end, when you have so many data further on. Nodule management protocol, difficult to get it. Again, something that you have to set up. Participants and data management softwares, as I said, they have to be compatible with healthcare IT system. It has to be a part of the healthcare system so that the whole screening can roll on its own during the time. In projects, it's different. You can really control it. You have the dedicated time for them, 1 year, 2 years, or whatever. And with this way of nationwide screening, you just want it to roll on. So it has to be a normal part of it. Enough adequate scanners, of course. We use those that we already had on 16 sites in the country at the moment, and we still have more of them waiting to be included. Enough educated thoracic radiologists, pulmonologists, surgeons, GPs, so everyone who participates in the program. Clear quality assurance requirements and continuous quality control. Again, continuous quality control takes time, and time is the main issue that we all miss for everything, and I think that we can agree on that. Continuous media support and public campaign, because without it, the interest drops. That's it from me. Thank you.
Thank you very much. Now it's time, Professor Chorostowska, about Poland.
Well, good morning. I am not really going to speak about Poland. Can I have my slides, please? I would just like to continue on what have been said about the lung cancer and how major health need it is in our societies. And I would like also to refer to many challenges that are linked to lung cancer, not only in terms of early diagnostics, lung cancer screening, but also lung cancer management in general. And I would like also to provide you with some overview on the new challenges that are coming linked to the early diagnostics, and that we can learn based on the experiences we are already have with more advanced lung cancer. So I will start with advanced lung cancer and show you the current status and potentially the further direction of development. So this is the current guidelines offered by the NCCN, so US national guidelines on treatment of advanced lung cancer. This is locally and systemically advanced lung cancer. As you can see, the diagnostics is pretty complicated with a complex, comprehensive molecular diagnostics, both for squamous non-small cell lung cancer as well as squamous cell lung cancer. Why? Because there are many new therapies that have been registered for advanced lung cancer, and those therapies has changed the the lives of patients with advanced lung cancer. Now we have the data showing that overall survival of those patients, it's much, much better if they respond to treatment. So here you can see the overview of currently approved treatments, many of them, many targets, many reasons to shape properly your clinic, to involve multidisciplinary team. You have already mentioned there is a need for multidisciplinary in lung cancer screening as well, and not by chance. So in advanced lung cancer, we have many different specialists involved in diagnostics. As I said, biomarkers shown here. New are coming. The field is progressing rapidly and fast. New treatments, new biomarker, a lot of research, but that all of that means new promises, new perspective for patients, but also new challenges for us and for the system. This is very important because that means not only the organizational challenge, but also a challenge for healthcare policy providers, for the payers, of course. So the diagnostics is complex, is expensive, but it's much, much more effective than 10, 15 years ago. And if we speak about the modern technologies, new generation sequencing now has become a standard diagnostic procedure. Here I am offering a glimpse into the current guidelines, because now we are not really discussing whether to apply this very modern tool to diagnose patients, but how to report the multiple findings that we see in the new generation sequencing. So again, that means expert knowledge and experience of the center. And I said that we have a wonderful data, and this is just one of the examples. Immunotherapy in advanced lung cancer. You can see the 5 years follow-up of those patients. Advanced lung cancer, stage 4, and almost 32% of them live 5 years from the start of the treatment. Just as a reminder, in the previous years, for chemotherapy, the life expectancy was 5 to 7 months. Here we speak about 60 months. So this is a big change. And the same is true for targeted therapies. Here you can see the observational publication, observational study from French network centers managing patients with lung cancer. So those are real-life data, and you can see the patients treated with sequenced treatment. So diagnosed with ALK rearrangement, treated for that with dedicated ALK inhibitors in the first and second and potentially third line. This is a sequence. And as you can see, median overall survival is close to 90 months for patients with advanced lung cancer. So that speaks for the fact that in advanced lung cancer, we are able nowadays, with the proper organization, proper system, many experts, to really increase the life expectancy for patients with advanced lung cancer. And this is a majority of patients, and as you heard from Professor Vashakova, most patients are diagnosed late nowadays. What does it mean for us in the context of the new opportunities, lung cancer screening? Well, it means that lung cancer screening is a very complex process. You have I think you have presented, as well as previous speaker, you have presented it really well, but I would like to add to the complexity. Because nowadays, as you know, we already have new registrations for early lung cancer in terms of combining the surgery with the pharmacotherapy. So we have new registrations in the adjuvant or neoadjuvant setting. That allows us, and I'm going to show you some data, to improve the life expectancy even more for the patients. So that means that all the complexity that I have mentioned in the context of advanced lung cancer, nowadays involves also the patients in early stages. Molecular diagnostics, complex and expert workup involving many specialists. And this is the example of current guidelines produced, and this is the 5th version for this year only, as you can see. So as I said, the progress is truly rapid. So those are the guidelines for the early stage lung cancer, and as you can see, I marked it in red. That also involves the molecular diagnostics in operated patients, because nowadays we could treat those who present with the EGFR mutation. Those patients are eligible for the treatment in the adjuvant setting. So after the surgery, if they are diagnosed with the mutation, they could be treated. And please, I would like to point your attention to the fact that here we are looking at the DFS, which is disease-free survival. And in treated patients, the median DFS is 65 months for now, versus 28 months for those who are not treated, not followed with the treatment. So that means at least twice as more, and that means that the risk for recurrent disease is more than 70% lower in the treated patients. This is a fabulous result. That really means that our patient can live nowadays much, much longer if treated properly. This is the same group. And this is also true for different kind of therapies, because we nowadays have the registration not only for the adjuvant, for the molecular, but also immunotherapy. And as you can see, this is a registration as of the last year for neoadjuvant immunotherapy in patients with lung cancer. So my point is that nowadays we already have new therapeutic options for patients, and the screening becomes even more important, because that means that we can apply new treatment options for patients at early stage. Therefore, the early diagnosis means not only surgery, but even more, potentially more for patients at the stage 1, but also stage 2 and 3. That means that the complexity that we face nowadays for advanced lung cancer extends to the early cancer diagnostics and treatment as well, with potentially much, much better outcomes that we see nowadays. Again, we don't have good data for the early cancer, but here are the data for advanced lung cancer. This is American study showing actually on the right-hand side that if patients is diagnosed molecularly, if the tumor is characterized molecularly prior to any treatment, then you can see that overall survival in those patients represented in blue is much, much better than if this is not done or done after the first line. That actually is indirect, I think, proof for the fact that we need to support lung cancer screening with not only properly designed programs for screening, but also all that comes afterwards. So the proper workup of incidental findings, but also the proper diagnostics and proper treatment of those patients. And only then we can truly analyze the cost efficiency, because cost efficiency is actually how long the patient lives after the diagnosis of lung cancer. Thank you very much.
Thank you very much. So now I pass the floor to Professor Adam Maciejczyk and Dr. Aleksandra Studer from Lower Silesian Oncology Center, and they are co-creator of Polish Hospital Network, Oncology Network. So the floor is yours.
Thank you.
Okay, thank you very much. We are honored to be here with you. We are, of course, after 3 such meetings. and I think that we want to sum up our findings, our recommendations from these 3 meetings. First of all, I have to say who we are. We are from regional center, from regional oncological center, from Wrocław. Our hospital called Lower Silesian Oncology, Pulmonology and Hematology Center. And we have yearly more than 7,000 primary cases, newly diagnosed cancer cases. We are in 4 locations, 2 in Wrocław and 2 apart from Wrocław in Legnica and Jelenia Góra. There are our satellite radiotherapy departments, and when we have started our meetings, our Oncoroundtable meetings, we were a Lower Silesian Oncology Center. Now we are after joint action with Lung Disease Center, and we are Lower Silesian Oncology, Pulmonology and Hematology Centers. So the problems with lung cancer patients are extremely important now for us. Because the whole pathway of lung cancer patients will be our work now. And our structure areas, our 2 comprehensive initiative in Lower Silesian Oncology Center, IPAC project and National Oncological Network. So in 2021, we have awarded extremely important for us such award, value-based healthcare dragons grant and endorsement. It was Polish competition. And in the case of this Polish competition, we have awarded 2nd place in international concept of this competition for introduction of pilot program of National Oncological Network. As you can see here, Professor van Enenman and our Dragons Grant and Endorsement report, they recommend to disseminate the concept of networking in every 5 types of cancer that were in our pilot program. Which initiative we have participated in before? Of course, this National Oncological Network, and we are now after completed our report from National Oncological Network. It's not only report from quality indicators, but we have there many recommendations how to build a network and how to build a quality monitoring system. Extremely important, because we would like to have such quality monitoring system in our country, in every hospital with oncological care. And the second one, our certification program, we are after awarded our certificate in CCCN, in Comprehensive Cancer Care Network, in colorectal and in pancreatic cancer. This was on the basis of ECC certification program, so European Cancer Centers, here in Berlin with Professor Tit Albrecht and with Simone Wesselmann. Like this topic today, multidisciplinary approach, coordination and networking and innovative are the most important topic also for us, not only for today Oncoroundtable meeting, but for our approach to comprehensive cancer care. And as you can see, multidisciplinary approach. Of course, the main point is multidisciplinary tumor board. We have now such schedule after certification with all of the multidisciplinary tumor board with 5 participants, not only surgeon, radiation oncologists and medical oncologists, but with radiologists and pathologists too, sometimes via vision track, sometimes on site. But the second most important in our hospital is now to build a comprehensive network. Comprehensive network in the field of quality monitoring system, and we have such meetings like quality circles, and we want to improve our quality in the field of such meetings. Prostate cancer. This multidisciplinary approach in prostate cancer. In our center, our patients take part in multidisciplinary tumor board in the case of decision sharing approach. And in lung cancer, it's extremely important now to optimize the decisions because even such molecular tumor board we should organize. In our center now we have boards with medical oncologists, but via telephone or via vision track we have pathologists and even pathologists that are dedicated for molecular diagnostic. And why this coordination and this networking is extremely important, we know, but we should know that it should be inside the hospital with, of course, patient-centered care. In Poland, we have such patients navigator, and I think that they are necessary from the diagnostic to follow up, not only since the point of multidisciplinary tumor board. And external network should be not only inside hospital, but external too. And it's important in many tumor entities. So from the last Oncoroundtable, this about liver and pancreatic cancer, we have such a cooperation agreement with small hospital with endoscopic ultrasound biopsy. But we have to say that now we want to cooperate with another hospitals, smaller hospitals, in the case, for example, of endobronchial ultrasound in lung cancer, because they have many more free slots for patients. So I think it will be good cooperation, and from such cooperation we have to have the same quality indicators, same quality policy. It's very important. So this cooperation partner should have this the same. These cooperation partners should have the same quality measures and quality policy in the case of reports, in the case of descriptions, for example. And innovative approach, it's of course about the diagnostic procedures, images procedures, genetic and molecular diagnostic procedures, and of course formulas. Tumor documentation is extremely important too, because we should digitize this tumor documentation. Even the best diagnostic accelerator is not the good solution without good description. Here we have digitized report in chest CT resume with TNM staging. In our certification program, it's extremely important not to have only description, but have the proper description. With, for example, description of enlarged lymph nodes, enlarged lymph node groups. It is very important for diagnostic procedure. It's very important for clinicians, for example, for radiation oncologists too. And new is coming now, because we are after this joint action, as I said before, with the Lung Disease Center. We are waiting for a CRANE joint action in the case of lung cancer certification. We would like to have a nominee for such certification, because we want to have the same pathway for our lung cancer patients in every of our localizations. And the second, as Professor Van Poppel said before, we are waiting for our action, for our combined action with Professor Van Poppel. Our uro-oncological unit would like to have this prize project, which the head of the department with Dr. Tupikowski, who is the head of our uro-oncological department. And of course, we want to have objective quality indicators, objective quality measures. I think it's a good recommendation for every hospital for benchmarking through the whole Europe, through the even hospitals not only in the Europe. As you can see, a few weeks ago, we take part in a German Cancer Congress with, and the certification program was extremely important because we know now, after many publications, after many articles, that patients that are treated in certified centers have better outcomes, even better survival, and the best outcomes are in lung cancer certified centers. Even China patients have now can now take part in this. Can be treated in certified centers, because we have such a certified center in Shanghai now. And a few days ago, we have extremely important for us meeting in ECC Commission, and we had a lecture about update of our recommendations from certification program. And thank you very much. We want to add something.
Yes, we would like to and of course to Agnieszka Sztek. Myślę, że nie mamy połączenia. Okay. Special thanks for organization of all Oncoroundtables. Very important for, and it's a big honor for us to participate in your speech.
So now we come back here. Please. Speakers. Thank you very much. Thank you for being with us for this all series and all meetings till today. So now Professor Lambert from Czech, and about prostate. Yes, we come back to prostate.
Hello, good morning. Thank you for your invitation. I will talk about both topics, lung cancer screening, as already said by Professor Vašáková, and also by screening of prostate cancer. And I will be very economical with time because we are about 30 minutes behind schedule, aren't we? So first of all, I'm a radiologist, so I see it from my perspective. What I see in Czech lung cancer screening is what has already been said, is the low interest among smokers. So the Ministry of Health made a huge campaign. The faces of the campaign were repeatedly on TV, but still we have just 1,000 patients or probants, smokers coming for lung cancer screening. Perhaps maybe there should be some time to revise our strategy and perhaps put the stickers on the packs where you see that there is lung cancer, you will die. Perhaps just some web page to say you can enter the lung cancer screening just on the packs because everyone has to buy it. Or perhaps another idea to make an entry during a football match. So this will probably spread the word across more patients. Secondly, what I appreciate very much and what you said in Croatia, it also happens in Czech Republic. We have still better machines that decrease the radiation dose from lung cancer screening. Currently we have 0.2 on a middle level machine, and the newest machines make 0.1. I myself had about already 2 low dose CT scans, because when I think I have some finding, I know that it's much better to undergo CT with such a low dose rather than X-ray when I am quite unsure whether there is not an interstitial lung disease or some minor finding. So I think that the radiation dose is so low that in many cases it will be preferred compared to chest radiography. Finally, what I appreciate on lung cancer screening is the amount of data we get from the patient, not only about the lungs, but you can see here the vessels, the coronary arteries. We know that we can derive calcium score even from non-gated studies, and we see the spine and we can screen for osteoporosis. And by this, I thank you very much for those who were introducing this screening. Here, Professor Vašáková from the radiologist, it's Professor Mirka from Pilsen, and of course the Ministry of Health. Secondly, let's skip this and go to prostate cancer screening. A week ago, the Ministry of Health hosted a Prostate Forum, and Professor Van Poppel and Monika Robol were gladly invited and shared their knowledge. And what I commend very much is from the European Union, from these people, that they give us some hymn sheets, how to start, what should we touch on. What is staggering with screening is that it is with lung cancer screening, prostate screening, is if I were a smoker, when I came to Czech Republic, when I came to the UK, to the USA, I would get different approach for the same condition, for the same risk. So if you consider, for example, the subsolid, the non-solid lesions, the ground glass opacities, in the USA, there is a threshold 30 millimeters. It was raised from 20 to 30 millimeters. In Czech Republic, it's 8 millimeters. So this is a tremendous discrepancy. And the reason is that we based our screening on the Nelson trial that was started more than a decade ago. And since then, we got some data. For prostate screening, compared to lung cancer screening, it's much more difficult for the radiologists. In CT, you try to find some nodules that are clearly delineated. You have a CAT algorithm and automated measurement, so it's no-brainer. However, in prostate screening, you should have a very well-trained radiologist who is knowledgeable about findings that can mimic cancer, so that you are not sending patients for needless biopsies just to be sure that you do not miss something. You have to follow the strict rules. And everything this has to be taken in the perspective of other diseases that are killers, that we have to deal with as well, and in the perspective of global problems. Thank you very much.
Thank you very much, Professor Lambert. So now we go just straight to Romania and to Professor Gabriel Caxo.
Hello, everybody.
Hello, we can hear you. So please, the floor is yours.
Thank you for the invitation and for the opportunity to hear how other countries are dealing with it. And it's reassuring that we are on the same page as a European country. It will be rather an easy task for me because I can rely on other speakers just said. I'm a professor of radiation and medical oncology based in Cluj, and probably a little bit particular in this European setting. I am part of a European chain of radiation oncology, which is operating radiotherapy and medical oncology in Austria, Italy, France, Poland, Romania, of course, and United Kingdom. So we are together since 10 years now, from the beginning of this amethyst part. And fortunately in Romania, this is reimbursed, I mean radiation oncology and medical oncology by the social security system, irrespective on the private or public health. So we are a rather medium-sized country as opposed to several ones presenting today, with rather a younger population median age. But of course, that will change in any circumstances because of getting an older and older population. As a radiation oncologist, when we are comparing to the criteria set by ESTRO regarding the coverage of radiation units, we are at 75% now, with quite quick steps in the late 5 years. But there is still a big disparity regarding how those radiation facilities are spread all over the country. So I am somewhere in the middle of Transylvania, with 7 LINACs in Cluj, which is a 500,000 inhabitants city. You can notice on the lower part in Bucharest, there is a third, almost 1/3 of the radiation facilities are in Bucharest or just neighboring areas. And that disparity is of importance because, as you know, radiation therapy is mainly ambulatory. And that needs to be re-examined in the next years. And I'm sure that in the next talk, Dr. Păun, which I'm seeing it attending physically, is going to sustain our cause. And that disparity is also true for diagnostic. We do not have pneumologists all around the major cities, and especially being able to do bronchoscopy or EBUS or EUS, endoscopic assessment. And when it comes to radiation, brachytherapy, it's very rarely used. I'm talking now for prostate. And stereotactic radiation therapy also, it's with huge disparities, and this applies mainly for lung cancer in early stages, but mainly in stage 4 disease, to act with minimal toxicities on the oligometastatic disease. As to medical oncology, the clinical trials availability are not all over the country. I will not insist on our numbers, but that's clear. The subject for today, it's on the top for mortality, lung cancer, and even if not in absolute numbers, a huge mortality pretender, prostate cancer, because it's so high incidence and let's say onset the disease is rather slow. Generally speaking, the prevalence will be high, and that in relative number will give important number of patients. So we were addressing how to deal with those disparities and with a better coverage in several meetings on which I had also the pleasure to meet Dr. Paun, or regarding medical technologies for radiotherapy and for, let's say, imaging part. I'm not entering into those numbers regarding lung cancer already discussed today. We did a survey among 16 radiotherapy centers in Romania spread all over the country. So this brought quite a good evidence on what we were at the point of pre-COVID, so it's end of 2019. And we had, as some other countries reported in Central and Eastern Europe, 50% of stage 4 disease in lung cancer, where, of course, radiation therapy, it's a palliative setting with some very small exceptions of stereotactic radiation therapy, together with the progresses made in medical oncologies, which were underlined by previous speakers, mainly pneumologists. So how to deal? We identified two major parts. So increase the awareness on what is available in the present, and that's through the medical community, government, stakeholders, patients associations, group, and so forth, in order to give every patient the right treatment in the right time. And important also the guidance on how to get that in due time. So sort of navigator, because a lot of patients are saying to us, I was never aware of, and in the knowledge of what you are able to do nowadays. And that will imply, into our eyes, the mass media coverage. Maybe this is a good part of post-COVID, that we have the ability now to interact on distance. Accelerate partnership between public and private, NHA's reimbursement coverage for stereotactic radiation therapy, brachytherapy, mandatory MDT for accreditation, re-accreditation of health providers, and of course professional societies' involvement within Romania and in the European frame of ERTC, ESMO, and so forth, ESTRO. Of course, these were already discussed regarding the diagnostic, screening, imaging, molecular diagnostic. I won't insist upon. There are some good opportunities which are different when we speak about prostate as to lung cancer, but however, the imaging will increase in use, especially with MRI facilities for prostate and PSMA, and low-dose CT for screening. Oligometastatic disease plays a special role, especially for stereotactic. MDT was previously touched, and we offer a daily MDT in our setting, hospital, and also remote MDT for hospitals which do not have radiation oncology, only medical oncology. And of course, we are hoping that starting from January 1st, our national plan of prevention and combat cancer will improve a lot our ability to to deal structurally and in a very measurable way with those items that I presented to you. Thank you.
Thank you very much. So now our last speaker in this session, Dr. Ilya Gib. So thank you for your determination to wake up so early because you are in the United States at the moment. So Ilya, if you're awake still, the floor is yours.
I am awake once I see my slides, so I guess it's still a very good morning. It is for sure morning here in the United States. And I will be talking about the lung cancer screening, the lung cancer early detection, and the challenges that we face when we speak about early detection of such a disease as a lung cancer. A lot has been said on the importance of the early detection, and I'm glad I can also, once my slides are being brought up, I can then continue talking about the importance and what can we do next. So what are the challenges? What are the next steps? In order to just introduce myself, so I'm the Chief Medical Officer in Philips, responsible for oncology. My job and responsibility is building partnerships, and I am a radiologist. This is actually one of the reasons I cannot be present physically is because of the RSNA in Chicago. This is the radiology event, but a lot is being said about the importance of imaging and integrated diagnostics in early detection of cancer, including lung cancer. I do not have any disclosures, so no conflicts of interests, and if I will be referring myself to any of the papers, which I will bring quite some, there will be references up on the slides. Going on next, this is the slide on what is the importance of early detection. So you can see that obviously, and this was said already, we have a chance to treat cancer once it's earlier caught with the better chances of patient to feel better. But this is also a lot more expensive to treat later stage versus early stage. Now, I very much appreciated the talk that was earlier by Professor Korostovska, who mentioned that we have greater chances to treat later stages, but this is something that needs to be taken into account, that we go earlier, it's cheaper, it's better results, and I think that this totally makes sense. And why do we do this? Now, again, what holds us from accomplishing this, because you can see that as of today, and I'm bringing some primarily based on the US data, you see that only 16% of lung cancers are being caught up at the earlier stage. So I did a very simple calculation and I said, okay, if we can just add 42% more to the early stage detection, we can reduce the mortality by 50%. Why 50%? Because those national programs like Biden Cancer Moonshot is focusing on reducing cancer mortality by 50%, giving it 25 years. What I'm trying to say here is if we can somehow fix the problem of early detection of lung cancer, we can reach those 50% reduction in much shorter, hopefully, than 25 years. Now that's for lung cancer, but since we're discussing lung cancer and prostate cancer, I think it makes sense. What holds us from actually accomplishing this? Because already a lot has been said on the United States Preventive Task Force. It's not something new that United States Task Force was coming up with guidelines and eligibility criteria. So the first one came up quite some years ago. And if you can see on the right side, it shows that implementation of those eligibility criteria did not really fix the problem, because we went from 3.3% to just 3.9%. And if we look today, 87% of eligible patient population is not undergoing lung screening. So basically this means, and if you look at also the importance of lung cancer contribution to cancer incidence and cancer mortality, this is similar to the fact that, well, we approximately have 1.3 million people dying on the road accidents and annually, and 60% of this deaths are related to speeding and drunk driving or driving under intoxication. So imagine if 9 out of 10 drivers on the road were violating speed limits and were actually driving under intoxication. So obviously those rules are being enforced, but patient recruitment and patient undergoing screening, unfortunately, we have issues about this. I also have an explanation on why is this, and I will come to this in just a second. But the big news that just happened in the US just less than 1 year ago is the US Preventive Task Force has increased the eligibility criteria by including a lot more patients. And in general, those are the guidelines that now expanded the age, decreased the amount of PAC years for the smoking patients. So, and in general, we're dealing with 85% increase in the patient pool for eligible population and lung cancer screening. Does it mean that we have actually achieved the better coverage on the screening? No, it's just an increase on eligible population. And unfortunately, that's one of the bottlenecks in lung cancer itself. So one of the obstacles and the reason why we have this problem is there is a huge component that is brought by the patient itself. So very little percentage of the patient is getting screened. Only 1 out of 4 patients are returning next year once they got screened. And there is multiple things and reasons that could be in place, like stigmatization, lack of trust. But honestly, it really doesn't matter as long as we understand that we are missing the point by missing and not covering the eligible population. And it gets even more interesting, and I know it's been said already that the dose is constantly decreasing. So yes, indeed, we're dealing with a low dose CT. But if you also think about this, that still, if we are increasing the coverage and if we're increasing the eligible population and increasing the coverage at the same time, we're dealing with the fact that in population, we deliver quite a substantial dose. So therefore, some of the cancers might potentially be induced. Here's the paper that talks about that in approximately 108 cancers. So we induce one cancer by introducing low dose CT. By no means I'm trying to say that we should reconsider. No, there is a lot more benefit in catching cancers early than the potential danger of actually having those patients getting cancer from the CT. But here's another issue, and there is a lot on the side of screening. I just brought this one argument. There was a study just yesterday. It was a presentation at the RSNA that talked about another estimation on how lung cancer screening helps to reduce mortality. But the problem is that a large number of lung cancers occur in non-eligible population. In other words, if we screen each and every eligible patient, we're still going to miss 3/4 of lung cancers. Therefore, the screening itself cannot be the only answer. Well, what can be the answer to be added to the side of the screening in lung cancer early detection? I believe this is in addition to screening, which, by the way, you have a better numbers on the 5% positive. I see in the US approximately 2.7, 2.9% malignancy rate out of all the findings that are found at screening. But in the incidental findings, this is 25%. So if incidentally found lung nodule, there is a greater chance that this is a malignancy, actually quite substantially higher chance of the malignancy. So therefore, we can also be using incidental finding for early detection as long as there is a program. Now, the problem is that a lot of incidental findings, about 2/3 of incidental findings in lung are not being properly followed up, which was already mentioned earlier today. So the reason why I believe incidental findings is a great way to go is because, first of all, there is a lot of CTs. Annually, and I have global data, about 300 million CT scans are being done per year. Now, low-dose CT lung screening is approximately 5% of this. Now, if you also look at where can we find those incidental findings for lung cancer, chest is adding about 15% of all these examinations. So in total, that makes 20% of 300 million. So this is a lot greater coverage than any eligibility criteria that we may potentially have for any kind of a lung cancer screening program. The other thing that I want to bring up, well, before I close on my slides, is the fact that it takes a long time for the lung cancer to develop. Now, this is an interesting study that was showing that approximately 20 years that when lung cancer develops, I don't want to go into discussion whether that would actually is something that we can catch, but it's a lot longer time that we potentially have once the lung cancer develops than once the lung cancer is already there. Which means that if the lung cancer is developing with the patients, whether the smokers or non-smokers, never smokers, quitters, the problem is that, well, we're just waiting for the eligibility criteria to play for us. Well, we're waiting for the lung cancer to actually become a cancer. And I think that this is a way also to potentially prevent this. An incidental program can also be something that would help us there. So in order to conclude on what I wanted to talk about today is, first of all, detecting lung cancer earlier is an imperative. It is an important factor in battling cancer and decreasing its burden by all means. Now, early detection of lung cancer should include both screening and incidental lung nodule programs. Patient recruitment and follow-up scans remain one of lung cancer screening greatest difficulties. And this is what I also try to bring is screening focuses on population at risk. It by all means have to be done, but incidental lung nodule programs have very significant advantages for early detection, especially in non-eligible population. And I believe, especially in November, the Lung Cancer Awareness Month, I think we should also keep this in mind. Very much. Thank you for your attention.
Thank you very much. And because we are a little bit late in time, I am as a moderator maybe just introduce a short break. Let's like 10 minutes, like let's maybe meet 15 past 12. Of course, our online speakers are welcome to stay with us and listen the second session. And we just start the discussion at the end of this event. So now let's say like 10 to 12 minutes breaks till 12:15. So welcome after the short break, and now we are moving to systemic policy approach. So we're now discussing how we can make it happen and improve the patient care. And first, I would like to introduce Adela Magehar, Senior EU Affairs Manager in European Patient Coalition. So she give us overview what's happening from European perspective. So please, Adela.
Thank you. First of all, good afternoon, and I would like to thank the organizers for being in Prague with you today. I represent the European Cancer Patient Coalition, that is the umbrella organization for cancer patients in Europe. We have over 450 members in 50 countries in the European Union and beyond. And we work so as to ensure that patients with cancer have timely and affordable access to the treatment, to the best treatment and care available. And also we work to influence the European political agenda, to empower and to educate our members, and also to increase the role of patients in cancer research. And to start with, I would like to say a few words about the political landscape and also the policy tools at the EU level on cancer. So, in the previous mandate, during the Juncker Commission, there was no political will to do policy on health. During the 5 years of the Juncker mandate, there is absolutely no new strategy or legislative piece on human health. However, the things have changed now during the current mandate, during the von der Leyen Commission. And now we talk even about a European Health Union. And yes, the COVID pandemic has had an impact on how we do policy, and especially health policy at the EU level. And on cancer, as you know, we have the mission on cancer, that is the only mission out of the 5 missions proposed that is focused on health. And we have the EU Beating Cancer Plan, as you've already heard, and this plan, I must say, has ambitious targets and initiatives. But the plan comes after about 40 years since the EU has last published a strategy on cancer. And we also have the report of the Special Committee on Beating Cancer, the so-called BECA report, that has been adopted by the Parliament in the plenary session in February this year. Of course, there are other legislative pieces and strategies that are indirectly related to cancer, like the European Health Data Space, the Health Technology Assessment Regulation, the Pharmaceutical Strategy, and others. And it's also important to mention, especially that we are now in Prague, that the current Czech presidency has put cancer high on their agenda, and in particular the finalization of the revision of the on cancer screening. And this revision comes after almost 20 years, because the first recommendation on screening were set by the Council in 2003. Now, going back at the European Beating Cancer Plan, this plan states that 90% of the EU population who qualify for breast, cervical and colorectal cancer screenings should be offered such screening by 2025. And also the plan expands that population-based organized cancer screening should include lung, prostate, and under certain circumstances the gastric cancer. And the same aspect is also very well strengthened in the BECA report of the European Parliament. And I will stop at this report. Why? Because last year, while the Parliament was working at the BECA report that was aimed to strengthen the implementation of the EU Beating Cancer Plan, the European Patient Coalition has set up a working group on the cancer complications and comorbidities. And receiving feedback from this working group, I prepared amendments for the parliamentary report, and I prepared about 33 pages of amendments that I have sent then to all the MEPs that were members of the Special Committee of Beating Cancer. And fortunately, 70% of these amendments were incorporated in the final text of the Becca report. And there are some aspects that the Parliament, for which the Parliament definitely shows political will in terms of addressing cancer, and especially aspects related to inequalities between member states in access to cancer screening. The Parliament states very clearly that these inequalities result in lower chances of survival due to late diagnosis of cancer, and this represents an unacceptable discrimination of EU citizens based on their country of residence. Also, the Parliament acknowledges the delays in access to screening that happened during the COVID pandemic, and invites the member states to actually work together, especially in cross-border regions and isolated areas, to reduce the social and geographical inequalities in cancer screening and early diagnosis services. And also the Parliament stresses on the need for a functional cross-border healthcare directive that, by the way, this is being also revised at the moment, but unfortunately we don't see a common ground to finalize it, at least up to now. And then, of course, the Parliament calls on the Council to consider including the lung and the prostate cancer screening in the update Council recommendation, and calls on the Commission and the Member States to support, to found and to implement further actions aimed at raising awareness on cancer screening and promoting participation in screening, both among countries and also in the general population at large. And in September this year, as part of the EU cancer screening scheme that was set to put forward under the Europe's Beating Cancer Plan, the Commission presented its new approach to support member states to increase the uptake of cancer screening. And this guideline that the Commission actually published in September this year focuses on the detection of cancer at an early stage, and the objectives are on proposing recommendations that to increase the number of screenings and to cover more target groups and more cancers. And the Commission actually states that targeted screening should be extended to other cancers, notably prostate, lung, and gastric cancer. And for lung cancer, the Commission states that lung cancer testing should happen for current heavy and ex-smokers aged 50-75, and prostate cancer testing in men between up to 70 years of age on the basis of prostate-specific antigen testing and magnetic resonance imaging scanning as follow-up. So yes, at EU level we have the necessary political will. However, the barriers and the resistance comes from the national level. And the last variant of the cancer recommendation on cancer screening that I've seen was dated from 18th of November. It was the document that was actually put to vote by the Council, by the EU ambassadors, the so-called Coreper 1, last Friday. And what is actually obvious looking at this document by comparison with what the Commission has initially proposed is that the Council has pretty much diluted all the good recommendations included in the Commission proposal, especially for lung and prostate cancer. And in both cases, so both for lung and for prostate cancers, the Council claims that there is only preliminary evidence, and the recommendations are also very vague. The Council makes really vague recommendations in terms of lung and prostate cancer screenings. There are no specific countries, and actually The recommendation leave it on the member states to decide and evaluate by themselves how to define the high-risk population to be scanned, to be screened, and how to improve their screening schemes based solely on their internal capacity and resources. And at the beginning of November, because the European Cancer Patient Coalition holds the secretariat for the Challenge Cancer intergroup in the Parliament, I have organized an internal meeting with the members of the European Parliament that are members also in this intergroup working on cancer, and we discussed particularly the Council recommendations on lung cancer. And as a result, we drafted a declaration that was actually signed by 48 members of the European Parliament, and that was sent to the Council. The main scope of this declaration was MEPs telling the Council to recognize the high burden of lung cancer and take the evidence-based necessary steps to help minimize this burden through ensuring lung cancer screening and optimization of the care pathway. And the declaration stated very clearly that lung cancer screening evidence is not preliminary, and that lung cancer is the leading cause of cancer death in Europe, and this has also an economic burden estimated at about 100 billion euros annually. Unfortunately, the Council didn't consider the suggestions of the members of the European Parliament, and I must say that this is really frustrating. And it's frustrating, first of all, to see that the Council recommendations don't align at all with the current EU ambitions in terms of cancer and on health in general. And we saw that both the European Beating Cancer Plan and the parliamentary, the BECA report, give high importance to propose clear measures to address inequalities among member states in terms of access to healthcare and in terms of how cancer is taken care of at the national level. So while at the EU level we have so much political will to tackle inequalities, we have the Council saying the member states should invest in screening solely based, as I said, on their capacity and internal resources. And by doing member states already do this, and they've already done this. Addressing screening based on their internal capacity and resources. So if we keep doing business as usual, first of all, we impede progress in screening, and then we even deepen the already existing inequalities that we have at the EU level. And the position of the Council is definitely the result of patients not having a stronger voice in the national context, first of all, and this is because the member states did not invest in health literacy to actually empower patients to have a voice. And I would like to stop here, but I'm happy to take questions at the end. Thank you.
Thank you very much. So now I would like to warmly welcome and introduce Professor Piotr Rutkowski from Poland. And Professor Rutkowski is the current president of Polish Oncological Society and also connected with National Oncology Center in Warsaw. So Professor, the floor is yours.
So good afternoon. Thank you very much. My name is Piotr Rutkowski. That's true. I represent Polish Oncological Society, but also I will be speaking on behalf of Polish National Research Institute of Oncology when I'm responsible for coordination of National Oncological Strategy. So, of course, I will focus mostly on the local issues and how it's organized in Poland and how it will be organized. And of course, I have to stress that Polish National Oncological Strategy is, of course, in line with Europe's cancer beating plan. And also we included the voice of patients, and now we also started the program for what has been mentioned by the previous speaker for patient empowerment for in terms of guidelines and working in oncology field. So next slide, please. Okay, You may see here the trends which we can see for lung cancer, prostate cancer, but generally in new cases in cancer in Poland. So we have huge increase both in males and females, but at least in last years we have more flat curve for a number of deaths. So what is a positive information? Next slide. And specifically, you may see here the breast cancer, when the incidence is increasing, but relative survival is increasing. But focus, next slide. Focus on lung cancer. We have a little bit decrease of incidence in males, but increase in females. And also the relative survival is slowly improving, what is mostly related in Poland to introduction of new drugs, of course. Next slide. But what is fascinating that we have a really dramatic improvement in the survival in prostate cancer. So first, of course, it's the increase to the awareness, better awareness of this disease. And second, that it's related also to new therapies which has been introduced. Next slide. So how it organized the oncological care in Poland? We have more than 23 public comprehensive cancer centers. Now it will be enforced into law as a national oncological network. We have still the shortage of specialists. However, we started a new proportional campaign of Ministry of Health for this specialty. Next slide, please. And what is important in terms of national oncological strategy, national oncology, one of the points will be national oncology network, which the last preparation of new law is within this month. So we hope that in early 2023 it will be organized by law in Poland with National Monitoring Center and Regional Monitoring Center, Cooperative Center. So the network will be fully organized, including some units like lung cancer unit, which I will mention thereafter. Next slide, please. So, and you may see here on this slide how the national oncology strategy for 10 years is built. We have 5 major areas, which which almost all are related to the topic. So prostate and lung cancer. So improvement of medical staff, investing in primary prevention and lifestyle, of course, tobacco control, investing in patients and secondary prevention, including the new fields in prevention like lung cancer, low-dose CT, maybe prostate will be also included very soon, and also the cancer care system. Next slide, please. So nowadays we are after 2 years of implementation of national oncological strategy. We can say that about 2/3 of our goals is implemented according to plan. So it's taking into account this pandemic time. I think that it's no bad now. And next slide, please. So on this slide, you may see the specific points related to lung cancer and prostate cancer. So, of course, for primary prevention, implementing legal regulation to support tobacco prevention policy. And it's described every year how it should be done. It's also very important that we increase the involvement of general practitioners team in improving cancer screening test participation. Now now it has been established. And of course, the next point, next slide, please, is improvement of the access to new drugs. We plan that till 2030, 90% of new agents will be reimbursed in Poland in cancer. And from 2024, lung cancer early detection and prevention screening tests will be universal health coverage, targeted high-risk groups. However, now it's available for the population as a pilot screening. And the next point, very important, that 2023 we will implement this national oncological network. And also lung cancer now, it's a little bit delayed, but it's finally established in 2023, also the lung cancer unit, and probably at the end of 2023, urological cancer unit will be implemented in the healthcare Polish system. Next point are, of course, the accreditation standards for pathomorphology laboratories. And the next point will be also for genetic diagnostic departments. This is planned for next year. And we are at the end of preparation of standard and guidelines for diagnostic and therapeutics procedures. Some are prepared by only Polish specialists, but by some are adapted from NCCN guidelines to Polish circumstances. Next slide, please. And at the end, I would like to also present what we are doing as a National Research Institute of Oncology. So we started Warsaw School of Cancer Epidemiology and Prevention. Next slide. So we have a lot of trainings now, which are starting 2023 in different topics, but including tobacco control and preventions with the cooperation National Cancer Institute. Next slide, from US. Here you may see the first courses which will be provided. So thank you very much. Next slide. I hope that at least in brief, I presented what we are doing in Poland now and how we are changing the organizational system, looking at this type of cancers, which are most preventable or most detectable at the early stage. So the public policy can change something. And of course, lung cancer is the major killer still among all cancers in Poland. So it's topic number one. Thank you very much.
Thank you very much, Professor Rutkowski. So now I would like to introduce another speaker who just joined for the second session, Dr. Tit Albrecht, head of the Center for Healthcare at the National Institute of Public Health of Slovenia. But Professor Dr. Albrecht also is involved in the shaping policy on European level. So good afternoon, and the floor is yours.
Good afternoon, and thank you very much for the invitation and for the opportunity to present some views on early detection for lung and prostate cancers. I listened to the last part of the first with great interest. Topics have been dealt with in our previous projects on cancer policy at the European level. So this is an opportunity to present some of the views, positions, and conclusions. Of course, given that I'm a public health professional, I will sound sort of a devil's advocate in this meeting because I will point out exactly some of the concerns that actually are present in several member states. I would not dare to say majority of member states related to these two screening programs or early detection programs. So, of course, conceptually, there are many options for the establishment of early diagnosis in cancer. We can have early detection that can be based on the early detection already present. This is something that we are aiming at also in the proposed new screening programs, lung cancer and prostate cancer. Screening for early stages of disease or its precursors. In this case, we seek precancerous lesions, which is typical for for cervical cancer and for colorectal cancer, while in breast cancer, we usually already also are trying to detect early stages of the existing disease. Of course, as presented by the colleague from the United States, there are also incidental findings that can sometimes belong also to early detection through routine emergency procedures, or sometimes also some sort of general preventative checkups present in some countries, in some communities. Depend on the existing knowledge about a specific cancer. We have to know enough about the natural course of the disease, which I'm not going to say that we don't in the case of the cancers that we are discussing. Of course, accessibility of early stages or precursors of a specific cancer, whether it's accessible to diagnose. And I have to stress this, whether we like it or not, what is the availability of resources, human, technical, financial, and also let's not forget that cancer is not the only chronic disease that our policymakers are tackling with. So early detection focusing on screening programs. Of course, certain existing screening programs became promotion. So many people are looking at screening programs as universal solutions for early detection of cancer, early detection of cancer in general. But of course, not all cancers are suitable for screening. And there is the need to adhere to Wilson's criteria. I did not decide to go into that here because I don't have the time and it's not the place to go so much into the essential discussion. But there are 10 criteria that need to be adhered to and fulfilled in order to go for a population-based screening. Some of the before have been talking about clinical indicated screening, opportunistic screening. Of course, in those cases, free conscription of interested patients or persons is always welcome. In some cases, good early detection strategies are better than embarking on a screening program, because in such cases, such a program might not give the best outcomes. Of course, something else that I need to stress, attention at the individual level needs to be given to family history as well as to potential risk factors in an individual. This is generic, not related specifically to the two cancers that we are discussing here. Traditionally, population-based screening includes all the members of a specific population in its entirety. I have to say that in one of the previous joint acts on policy, we had very lively discussions because our more traditional colleagues from public health were saying that, of course, some of the screening programs proposed are actually high-risk monitoring. And in the case of lung cancer, I'm also of that position. That's not screening because we have identified a subgroup of the population with a specifically increased risk factor that we are going to screen for, or let me put it better, monitor for. But I will come back to that later on. Traditional screening approaches do not support stratification. Whole population is included and it's supposed to be covered. In the recommended screening programs, we have two cancers where we screen for precursors of disease, which I mentioned already. This is cervical and colorectal, and one cancer where we try to look for early stage disease, which is breast cancer. Of course, the need for stratification has been clearly demonstrated in some cases. And this supports also the approaches that were proposed related to lung cancer and prostate cancer. Population is not amorphous. It's not, does not have a unique risk level. Identifying a higher risk group in the population is very important to avoid uneven outcomes, so that we really focus on those who will gain most from screening. Nevertheless, main focus is still on the first part of screening for the most part. Outliers require specific approaches. For example, early onset disease like BRCA-related breast cancer, or also other cancers related to this mutation. We cannot lower the breast cancer screening age to 20 years in order to catch all those women who have the mutation, to cover them, because we would expose unnecessarily hundreds of thousands of women to unnecessary radiation. But of course, we still need to remember that when we speak of screening, screening is meant for addressing the average risk in the given population, not specific subgroups. I will first address the issue of lung cancer. Lung cancer has for long been one where improvements were expected in survival. And some of the speakers have already indicated improvements also in terms of better outcomes of treatment and somewhat earlier detection. But of course, in absence of early detection strategies in the past, I'm saying, the main focus was on therapies, on treatments. Successes of some trials, in particular the Nelson study, show the potential for screening and its population impact. So not only at the individual level, but also the population level. Strictly speaking, again, I will assert this, I have to stress this from the public health point of view, we are talking about monitoring for an expected outcome in a high-risk population. Advantages and risks of early detection of lung cancer. Definitely advantages, I would say, are a reduction in incidence and mortality due to maybe more in mortality than in incidence, because we are actually detecting the disease, but we are shifting to lower stages and moving patients from untreatable to treatable disease. Secondly, we of course would reduce the overall burden of lung cancer, and I would particularly stress that former smokers would probably benefit from screening most. Having said that, I have to stress here one of the main concerns in the public health community related to lung cancer screening. And this has been partly touched upon by the speaker from the US. Heavy smokers are, and this has been proven by many studies, heavy smokers are psychologically a different group of population. They are hard to reach, and they are particularly motivated for preventive strategies, including smoking quittal. And of course, look at the landscape of smoking prevalence in Europe. I have to say that a country that has a smoking prevalence of 40%, in my view, should work first on a successful tobacco quittal and, of course, smoking reduction strategy. Because if we are continuing with a 40% prevalence on smoking, we will throw enormous amounts of money into lung cancer screening and treatment. Let's not forget about that. And some cancers will not definitely be treated. There will be transient effects as well. And of course, we can only introduce lung cancer screening with very stringent tobacco reduction strategies at all levels. I know that this is a part of EBCP, but I have to say that I would almost insist that no lung cancer screening can be introduced if there is no aggressive tobacco reduction strategy in place. We see that in subpopulations, and gender-related trends, which Professor Rutkowski addressed, have also shown that we have problems in our societies, also because of the delayed effect of women starting to smoke more. Secondly, screening for lung cancer in heavy smokers, but not in other at-risk populations, is also introducing some sort of a difference and inequity. Of course, we have evidence from studies only for lung cancer and heavy smoking. We cannot speak about environmental pollutants except asbestos. Of course, this has been covered significantly. So these would be my concerns. Finally, I will move to the early detection of prostate cancer. Here we have a different situation, partly also touched by Professor Rutkowski earlier. There have been decade-long efforts to develop correct use for PSA for screening, although this was originally intended for clinical monitoring. The problem is that imprecision of PSA alone, if used, to clearly distinguish two crucial categories: cancers versus infections, and aggressive cancers versus non-aggressive cancers. One of the explanations for the reduced mortality, namely, is in the fact that we detect many cancers that would probably never require treatment. And of course, by removing them, we are actually we are diagnosing men who would probably never develop metastatic disease or die from prostate cancer. What I am standing for is that, of course, an organized screening program for prostate cancer would improve the situation in most European countries from today's wild screenings, where, of course, we don't have enough data at the population level to be sure of any of the trends that are developing. We are looking only at ecological data. We are not basing our conclusions on individual case-based data from registries. Because in most cases from these wild screenings, we don't have data available in registries to follow up on the patients that have been really diagnosed. What would an organized early detection bring compared to the current situation? It would definitely bring more transparency and more concrete data and better insight into the real benefits of the population-based screening. There would be coverage of a significant proportion of the population. This population would probably be more compliant than other populations, as we have seen in COVID, but also in the colorectal cancer screening, and of course link outcomes to participation in screening, which is essential. Modeling the program according to the specifics of the given population. This is a remark I would give also for lung cancer. Pilots need to be run in all countries before introducing large-scale population programs. Thank you very much for your attention.
Thank you very much. So now I pass the floor to Dr. Diana Loreta Paun, Presidential Advisor, Department of Public Health from Romania.
Thank you very much, Agnieszka. My presentation, please. Good afternoon. It gives me a great honor and pleasure to be here today in such a select company, and I want to thank to the organizer for inviting me and for the opportunity to present the case study for Romania, the national plan to fight against cancer. Why cancer? Cancer because this is the most important burdensome disease in Romania after cardiovascular diseases and stroke. And because Romania unfortunately ranks the first in the European Union in the number of deaths from treatable causes and the third in the number of preventable deaths. For example, in 2020, according to Globocan, we recorded more than 98,000 new cancer cases and more than 54,000 cases of deaths. Lung cancer is the most common among both men and women. It is followed by breast cancer, prostate cancer, urinary bladder cancer, and gastric cancer. Among men, the most common is lung cancer, followed by prostate, urinary bladder, and gastric and liver cancer. And among women, the most common is breast cancer, followed by cervical, lung, endometrial, and ovarian cancer. Also, the survival rate 5 years after diagnosis in treatable cancers in Romania is far below the average of European Union. For example, for prostate cancer, 77% in Romania compared to 80% in the EU, and for breast cancer, 75% in Romania in comparison with 82% in European Union. So a strategy to fight the disease had to be put in place. And the steps were the follows. The plan was launched in January 2022 at Cotroceni Palace in the presence of President of Romania, less than a year after the adoption of the European Beating Cancer Plan. The event brought together all the stakeholders involved over time in the creation and development of such a plan. That means government, Ministry of Health, Parliament, patient association, experts, academia, researchers, and also industry. The plan followed the consultation procedure by the Ministry of Health, and on September 21st this year, it was voted in the Senate, and after that, in October 19, it was voted in the Chamber of Deputies in our Parliament, and President Klaus Iohannis signed at the beginning of this month, on 2nd November, in a ceremony held at the Cotroceni Palace, the decree for the promulgation of the law approving the national plan to prevent and combat cancer, in the presence of the Prime Minister of Romania, of the two presidents of health committees of the Parliament, of Romanian Ministry of Health, and of course in the presence of physicians, experts, officials, and patients. Which are the objectives of the plan? The main objective is to achieve a well-established and standardized patient route between the various levels of care for a multidisciplinary approach. And there are specific objectives: target the localization with the highest disease burden in Romania, that means colorectal, breast, cervical cancer, lung cancer, and also for hematological cancers. We have a different special chapter for pediatric cancers and also for rare cancers. The objectives closely follow the 4 pillars of the European Beating Cancer Plan: prevention, screening or early detection, treatment, and care. That means, for prevention, we want to implement a national strategy for the promotion of the concept of prevention, and also we want to build a national interconnected network in connection with European Union networking system. We want to measure the risk factor associated with cancer, and personal medicine is very important for us, not only in the field of prevention, but also in the field of diagnosis and treatment. Diagnosis means oncological patient route, personalized medicine, the introduction of immunohistochemical and genetic testing reimbursed by the National Insurance House, the settlement of this test in clearly established situations, and creation of a functional national cancer registry with sub-registries for all localization, well as the implementation of the electronic patient record in accordance with the European medical data source. Treatment means the introduction of innovative therapies, periodic update of medical practice guidelines and therapeutic protocols, the functionality of the tumor board and personalized medicine. And the fourth pillar, care, means promotion of palliation and also introducing new services like psycho-oncology, onco-nutrition, and onco-fertility. Last but not least, we want to promote research and innovation through correlation with the recommendation of the Mission Cancer mentioned by Adela. Participation in European partnership relevant to the topic of cancer, like European Partnership for Personalized Medicine and Partnership for Rare Diseases. Correlation with the objectives and activities of our National Institute for Research and Development in Genomic Medicine, recently created in Romania. Correlation with the research component of the National Recovery and Resilience Plan. Horizon Scanning Research Program for identification of different possibilities to implement in Romania, and of course stimulating the increase of the number of clinical trials. The measures provided for achieving these objectives have very clear deadline written into the law and include the complete operationalization of national screening programs. We want to have 5 different screening programs for colorectal cancer, breast, prostate, cervical, and lung cancer. The creation of a health innovative fund under the coordination of Ministry of Finance, which will provide Romanian patients with rapid access to the newest therapies. The creation of the National Cancer Registry, a multidisciplinary approach by developing a standardized way of working of the tumor board, using personalized medicine for the prevention, screening, diagnosis, and treatment, and increasing access to palliative care services, as well as providing, as I told you, psycho-oncological support and onco-nutrition in order to improve quality of life for the patient and their families. Of course, that we need money. My colleague from Croatia said that political will means money. That's true. We intend to use funds available from the state budget, from the national insurance budget, and also from European funds, National Resilience and Recovery Plan, and also other external fundings. And the target areas are infrastructures and technology, training of the personnel, mobile screening facilities, GP incentives, which are very important, as you said, digital monitoring, access to medicine, and clinical trials. Why is so important this plan for us? Because this national plan to prevent and combat cancer is a model and a result of a remarkable cooperation and mobilization between all the stakeholders representative for the public health domain, from authorities to patient associations, experts, academia, industry, and for us it is a model of health public policy in Romania. But we need still a public law on prevention and education for health, because prevention should be a mainstay of public health investment in this field. And in the prevention capabilities at the national levels is crucial. We know also we need investment to support health literacy, like Adela said, behavioral insights and cultural insights of our population, human resources training and abilities, and new models of care, because to be effective, we must ensure the real integration of prevention and treatment. And the pandemic and the current crisis means a quick adaptation to new realities. That means opening the way to new, the fastest way of care governed by digitalization and artificial intelligence. Thank you very much.
Thank you very much. So as we started with this session with the patient voice, we also end up with the patient voice, which is, I think, even the most important because actually all are here for patient. So I would like to introduce Petra Adamkova, chairman of the Czech Committee of the Voice of Cancer Patient.
Thank you. Thank you for inviting me. And I'm very happy that I'm here as a patient representative. And I will be very quick because we are running out of time. And just a short introduction of our platform, of our cancer patient voice. I think it's a good example of from the Czech Republic. We are a platform since 2019 of all an umbrella of all oncological and hemato-oncological organization in the Czech Republic. We have a legal entity since the last year, but we worked together since 2019, as I said before. I think we cover all solid tumors and hematology, and we are very active in all these areas. And I have to say that I'm very happy that I'm here in the Czech Republic because we are here heard as a patients and here. And since 2017, there is a really big patients empowerment doing the Ministry of Health. And in this time was established the Patient Council. It's the direct consultancy to Ministry of Health. We have also own department at the Ministry for support of patients. And we also have a really comprehensive education for patients, and I think it's very important because the education is the key for patients to be partners for professionals and healthcare policy and all stakeholders, also healthcare payers, healthcare insurance, and so on. Our cancer patient voice, we are 10. And 10 representatives, and we are really a good team, I think, and we have representatives in all these structural things on different levels in the Czech Republic. We have 3 representatives at the Patient Council and its working groups. Working groups are, for example, for innovative medicine or for medical devices and so on. And we are involved in these working groups, so I think it's very great. We also have 2 representatives in a National Council for National Cancer Plan implementation. And we were also involved in creating and updating of our national cancer plan since 2019. There were the COVID era, and it was not so easy to cover everything, but it was done. We have also representatives in National Association of Patient Organization, Czech Rare Disease Association, Patient Council of Masaryk Memorial Center, Cancer Institute, and so on. But what I found very important here to mention that we are also a part of Europe. We are now, as a cancer patient voice, will be, I hope, as associate member of ECPC, of European Cancer Coalition. And we also have some connection with Europe through European Network of Gynecological Advocacy Groups. And what is also very brand new, on December 1st, we will launch the Czech UPATI National Platform. It's European Academy of Innovation Treatment for Patients, and it will be also in the Czech Republic. And last but not least, we have close collaboration with our professionals, with Czech Oncology Society, with all relevant professional societies, and also with Professor Vašáková, she was here. What lung cancer and prostate cancer concerns, our members are organizations supporting patients in these two diagnoses. But we would like to following the Europe's Beating Cancer Plan and our national cancer plan, we established a new project called Patient's Pathway or Patient's Journey. And we would like firstly to map our journey from the patient point of view. So I mean the patient's eyes, through the patient's eyes. In the first 4 diagnoses, it's lung cancer, prostate cancer, breast cancer, and cervical cancer. And we would like to find the gaps also regionally through the whole Czech Republic. Then we would like to discuss it with all stakeholders, Czech Oncology Society, specialists, professionals, definitely with clinicians, and try to firstly establish the ideal patient journey in each diagnosis, and secondly, find the gaps to improve them. So it's really, I think, huge project, because from our point of view, we have to do a lot of surveys from patients to get patients' experiences and patients things and comments. But I think it's very, very important, because when we are talking about to improve better quality of patients' care and oncology care, so I think these all things together can be the goal or the target, and we can improve it all together with all stakeholders, with all patients together, and to have or to establish or to have a really good oncology care in the Czech Republic. So thank you very much. These are contexts.
Thank you very much. And after series of the Oncoroundtable, we have a set of recommendations, which I highly recommend to read and be familiar with, I would say. But as the final words, I want to give the floor to all our speakers to summary our kind of presentation. And first of all, because we know there is a lot of recommendation, there is a lot of good advices, but what is the main barrier really to implement? Is it money? Is it willingness? Is it the silos approach? Is this, I don't know, education maybe? So if you can with 1 sentence, 2 sentences summarize, and also give us like take away message, how we should really move forward faster. So maybe I start with the online speaker. I don't know if there are some with us, so maybe let's give the floor first. The online speakers, just a few sentences of summary. What is your takeaway message, and what is, in your opinion, the main barrier, 1 or 2 main barriers?
Okay, thank you. So First, I think that it's really willingness to implement Europe's cancer beating plan on the national level. So it's a great opportunity that we have such pan-European plan, and we would like to focus, of course, on primary prevention and cancer screening. But still, I do not feel that it's number 1 in many countries. Although Czech presidency told that, of course, cancer is on the top priority, but still I do not feel that it's a top priority in many countries. So this is first point. Second, of course, it's much more aggressive policy against tobacco. So tobacco control, I think that could change a lot on the European level, and we should do everything to be much powerful in this field. Because as Tits told, without that point, we cannot go with any screening with lung cancer, because it's nonsense to perform millions of CTs in the people who still are smoking cigarettes. So this 2 points, and of course organization of the healthcare on the national level. But these 2 things on the European level are top priority in my opinion. Thank you very much for the possibility to be here. I have to disconnect, unfortunately. Goodbye.
But thank you for joining. So, Dr. Tit Albrecht, what is your takeaway message, and why you think there is not priority in the many countries, beating cancer in a different treatment area?
Well, I think it's surprising that it's not a priority in many countries, because it's becoming the #1 killer of our populations. I mean, cancer in general. So in Slovenia, cancer is the main cause of mortality in men since 2007, as in many Central and Western European countries. And it's going to become a huge burden. On the other hand, I am surprised because, of course, although the investments are important, it's one of the few chronic diseases we can actually get cured of. And so we can actually get rid of the disease, which is not very common in other chronic diseases. One thing that we need to take into account, I think, is that we are in competition with other disease groups. There are strong, I heard from many colleagues who work in cardiovascular disease and diabetes and also neurodegenerative diseases, that now only cancer is given all the attention, and that that's not fair and so on. I understand that you have to focus, and the cancer is a good example of a longitudinal approach where we cover all the aspects of the disease, and we can address all the aspects much better than in other diseases. Finally, I think that quality of care and quality of life needs to be paramount. So patient in the center, patient pathways, patient monitoring of patient reported outcome measures, and patient-relevant outcome measures are also essential. Thank you very much.
Thank you very much. So, Lower Silesia Center of Oncology, Professor Maciej and Dr. Studer, what is your view on this?
Yes, we have only one short recommendation. We would like to recommend consistent implementation of European beating cancer plan, Polish strategy of oncology. We have so good documents, we have to do it incorrect. Thank you very much for all organization and collaboration, of course.
So thank you very much. So now we moved to our speaker here in Prague, Professor Horostowska.
I would like to follow on what previous speakers had mentioned. I think we are nowadays in a very sensitive position because on the other hand we have the Europe's beating cancer plan, but as we have heard today, the position of the European Commission has been very much diluted, unfortunately. So for me that speaks that while we have a solid data, at least for lung cancer, I can speak about lung cancer, and we have a very positive position of the European Parliament as represented by the BICA report as well as SAPIA mechanism. So both speak about the solid scientific data on efficacy of lung cancer. On the other hand, we have a political position of the ministries of health, which actually speaks about low quality of scientific data. So for me that really emphasizes the need of a very strong collaboration, even better collaboration between patients' organizations and the scientific medical association, because one voice really might make a miracle. This is a European level. At the country, at the national level, this is what have been emphasized by Polish speakers. We have a national plan. We actually in Poland have a wonderful collaboration between different specialist groups within the lung cancer. So what we need now, we need to push for implementation for the lung cancer units that would not only be an administrative creation, but also would be truly implemented into the real-life management of patients. Thank you.
Dr. Marusic?
Thank you. Well, recommendations exist. Stronger or unfortunately weaker, but they are out there. Croatia has shown that it's possible, that it's feasible to make lung cancer screening running. We are going to stay critical to it, to look to downsides of what we do, just to improve our own program and to show others how to do it better from the beginning. So I hope that our work is going to help others for implementation and make that positive effect to everyone else. Thank you.
Thank you very much. Dr. Paun?
My message is one of collaboration. Yes, I think that solidarity is key. Working together, sharing experiences, learning from each other, and coordinating our actions will lay an incredible foundation for the work ahead. Thank you very much for the invitation.
Thank you. Professor Lambert, your final words?
Thank you very much. I'll underline the need for implementation because we have the data. We know that it helps patients and that we save money. So let's just do it, implement it, and it will work.
Thank you. So the patient voice, Petra, and then the last, like the...
Okay, thank you. I think the collaboration is crucial and invites patients and patient organization in the plan and in the planning and in implementation. And I think it will help also in the local level, on national level. Thank you.
Adela, how we can strengthen this cancer beating plan, yes? Is it possible still? Or?
The European beating cancer plan is definitely a successful story at the EU level. The question is, how can we make it a successful story at the national level, because in the end, that's where the patients are. And I think that it's time that no matter where you live, in your small corner of the world, be sure you are the difference and you drive the difference. And I think that the Central Eastern European countries are very well positioned to show Europe at this time that they can start the best practices. Because no matter what the, let's say, more reluctant voices in the Council say, we are, as Central European countries, we are a power, and it's time to show that also the change can start from us. And yes, collaboration is key. Thank you.
So thank you very much. Thank you for your participation, for your important voice and knowledge sharing, and goodbye then.